This program is presented by University of California Television. Like what you learn? Visit our website or follow us on Facebook and Twitter to keep up with the latest UCTV programs.
We'll get started today, and our speaker today is Dr. Elizabeth Bromley, who's an assistant professor in residence and director of the Ruth Carr Program for Physician Vitality in the Jane and Terry Semel Institute Center for Health Services and Society within the Department of Psychiatry and Biobehavioral Sciences. Dr. Bromley received her MD and MA in the History of Health Sciences from UCSF, her PhD in Anthropology from UCLA. She did a residency and a chief residency in adult psychiatry at Columbia and the New York State Psychiatric Institute. She came to UCLA in 2003, did a fellowship in intervention research, and was a Robert Wood Johnson Clinical Scholar, followed by a psychocultural research fellowship. She has been the recipient of various honors and awards, including the Social Work Spotlight Award from the VA Greater Los Angeles Healthcare Center in 2011. Her interests have been funded by a number of organizations, including the CTSI Scholar Award, NIEHS from the NIH, and the UCLA Department of Psychiatry and the California Tobacco-Related Disease Research Program. She has published about 16 peer-review articles, 3 book chapters, and has participated in various symposia and invited lectures. So the title of her talk today is Physician Burnout, Depression, and Demoralization, Keys to Remaining Engaged and Energized in Pediatric Doctoring. This is a faculty development lecture series. So, Dr. Bromley.
Thank you. Thanks for having me come today. I hope that today's talk isn't too much of a downer. The good news, the fun things are really at the end, so if you can just stick with me, we will get there. I'm really going to begin with the heavy things, talking first about physician suicide because it's 8 in the morning. And I hope I can explain as I get through some of the data about physician suicide why I think it's very important to start there. I'm going to talk both about the risk rates for physician suicide as well as gender differences in rates of suicide. Then I'm going to say a few things about the particularity of physician suicide, the way that it looks to me to be slightly different than other kinds of suicides, and why that raises some questions for all of us. Then I'm going to talk more generally about work-related distress among physicians, what we know about that, particularly focusing on burnout just as one aspect of work-related distress. And I'll review some of the data on why burnout is important to think about, not just for our own wellness, but for patients too, and review for you some of the work-related factors that seem to contribute to burnout. Then I'm going to tell you a little about some of the approaches and interventions that have been used to lessen burnout and improve physician satisfaction and meaning at work. There's several options here, things like self-assessment as well as reflective practices. And I hope I can convince you that it's not that complicated actually to improve your experience at work as a physician. It doesn't take a lot of time, it doesn't take a lot of money. Small things can actually make a big difference in your own experience of work as a doctor. And I'm going to apologize in advance because I tend to sometimes, when I'm talking about this, lapse into a little bit of a pep talk, and I don't mean to do that, but I do want to try to motivate you to think about small changes you might want to try to see what works. And then at the end of the talk, I do want to highlight for you some of the things that go on here locally and some of the resources you might want to avail yourselves of. Sorry, getting used to navigating. Here we go. So really my take home is that I think really to think seriously about physician wellness, we have to recalibrate our expectations. And by that I mean that feeling exhausted, depressed, or irritable are not normal aspects of being a physician. They're not required. And I think, moreover, pushing through those feelings of exhaustion doesn't make any of us better physicians or good physicians. And I think giving that a little bit of thought is very helpful and actually quite radicalizing. As I said, I don't think changing our experience at work takes a lot of time, and it also doesn't require quitting, leaving your job, or leaning out, giving up, working less. There are small things we can all do. It does take a little bit of experimentation. This is something people talk to me a lot about. Trying things and seeing what works is very important, and committing to that, trying some things over time. What doesn't work, try something else. That's very important, and that's practice, and with some practice, things do get a little bit easier. So, with that in mind, this is Ruth Carr. The reason I'm talking to you today is that in 2009, May of 2009, Ruth Carr, who was a plastic surgeon who trained here at UCLA and practiced in Santa Monica, killed herself. May and June, actually spring, is the highest risk time for suicide generally. Yesterday's the first day of spring. We have some poppies coming out on our hillside. Doesn't seem like a time that would be a high risk for suicide, but it is. May and June are actually the highest risk months. Dr. Carr didn't have any of the classic risk factors for suicide that we tend to think of. She was depressed at the time of her death, but she was not a person with a history of a serious mental illness or with serious symptoms throughout her career. She was very successful. She had a loving family. She had many old and new friends. She was uniformly upbeat, optimistic, engaging, warm, beloved by her patients. And her story is very complex, and I'm working on a book about this, but one thing I do want to point out, she was very isolated at the end of her life. She wasn't able to reach out for help. Those around her really weren't aware that she needed help, and I think the isolation she experienced in her depression is quite troubling and something we all need to keep in mind. So I'm going to say a lot today about the importance of community and keeping track of one another, and in part it echoes her experience. So physicians are at an elevated risk of suicide. 300 or 400 U.S. physicians a year die by suicide. That's 2 medical school classes each year. And the estimated relative risk of suicide is elevated both for male physicians and female physicians compared to the general population. Other estimates besides relative risk show suicide might be about 70% higher for male physicians, between 250 and 400% higher for women physicians compared to the general population. Overall, in the general population, men's suicide rate is about 4 times higher than women's. Women attempt suicide more often, but men commit suicide more frequently than women do. But among physicians, those rates seem to be approximating. So that's very unusual, and that's something we see in other populations, other age cohorts, even cross-culturally, we don't see that. But among physicians, suicide rates are approaching one another to be approximately equal among men and women. This is just here on your left, suicide rates among male physicians. You can see here the orange line is the summed from this meta-analysis relative risk rate, and here you see the confidence intervals. So this is, there are some studies that don't show an elevated risk of suicide for male physicians. Here on the right, we see the same data about women physicians. Very consistent picture that women physicians are at a higher suicide risk rate than the general population. This is just another table that shows not a comprehensive list, but a whole set of articles about physician suicide and the rates of for men and women. These are data from the US and from Scandinavia. And in the majority of these studies, all but 3 of these studies, rates of suicide among male physicians is higher than the general population. And all of the studies shown here show an elevated risk among female physicians compared to the general population. So that's a consistent finding, but actually it's interesting to look at some other comparator groups besides the general population. So in general, high status occupations tend to show a lower suicide risk compared to the general population. So higher SES occupations, higher status occupations tend to come along with a lessening in risk of suicide. And that's been shown in using many different methods. But even compared to other professionals, physicians' suicide risk appears to be elevated. So the rates for men compared to other professionals is still elevated at 1.5 to 3.8 in this estimate, and 3.7 to 4.5 in women physicians compared to other women professionals. And another way to look at something similar is that physicians have a lower mortality risk from all causes except from suicide. And so here is the table from this study from 2005. And you can see here in the for men and for women, the standardized mortality ratio for various causes of death, lower than the general population until we get here to suicide, 1.82 for men and 4.95 for women. Now this estimate from women comes from a relatively small sample size, and so the estimate is much less precise, but it's striking to see physicians generally are healthier and are at a lower risk of death from most causes except from suicide. So what could explain this elevated risk among physicians? The most common correlates of suicide, we think of mood disorder and substance abuse as major risk factors. And so perhaps it is the case that among physicians these disorders are more common and may account for some of the elevated rates. It is the case, and this has been much discussed, that depression among medical students is quite prevalent, and compared to peers, medical students have high rates of depression, 18% in women and 9% in men. But the studies that have been done in practicing physicians shows a similar rate of depression compared to the general population. So there are some problems with these data measuring depression among physicians. It's all self-report data, which has some limitations, but there haven't been consistent reports of elevated rates of mood disorders among women or men physicians. And rates of substance abuse appear to be about the same as they are in the general population. So this isn't a great explanation for the elevated risk for physicians. Another hypothesis about excess suicide mortality among physicians attributes this to physicians' access to means. Certainly we do have access to drugs and know how to use them, and physicians are much more likely to die by overdose by using those lethal means. And some have postulated that the gender disparity in suicide rates that we don't see among physicians is attributable to women's access to means. So if women attempt suicide more commonly than men and female physicians have access to lethal means, maybe that's why we see this approximation of suicide rates and a high risk of suicide among female physicians. And there's some data that indicates when women have access to more lethal means of suicide, their rates of suicide are much higher. So places in the world where pesticides are readily available. And also an interesting study from Australia looking at a policy change that made barbiturates much more readily available. They showed an elevated completed suicide rate for women in that group. One problem with this theory is that it actually looks like it's not so much suicide attempts that are more common in physicians, but suicidal ideation. So actually looking here at the bottom, the attempt rate among women physicians in this study is much lower than the general population. So suicide attempts tend to be reported by about 3% of the general population and 4% of women, and that rate is lower among female physicians. Again, these are data with a lot of problems. If you ask someone to self-report whether they've ever attempted suicide, you have to contend with some limitations to that data, but it does appear to be at a lower rate than the general population. What's striking is a number of studies, recent studies, that show that suicidal ideation is fairly common among physicians. So 6% first in this large sample of physicians, 6% in a smaller sample of surgeons. That's about 3 times more common than the general population. A very interesting study from using an analysis of about 200 suicides from the National Violent Death Reporting System it says that the picture of suicide among the physician suicide victims was substantially different from that of non-physician suicides. So the physicians who had killed themselves were more likely to have had recent job problems. They were less likely to have had recent death of a friend or a loved one, which is a very significant risk factor for suicide in the general population. There's a greater likelihood of a known mental illness, but a much lower likelihood of antidepressant treatment. And surprisingly, physicians were more likely to have measurable levels of benzos, barbiturates, and antipsychotics in their blood at the time of death. And the authors don't really have a good explanation for this, except to suggest that perhaps a lot of these physicians were trying to treat their own mood disorder and choosing to use antipsychotics and other medications that may not have been helpful. Certainly barbiturates may have been the cause of death for some of these physicians, but it really substantiates something we know very well, which is that many physicians don't seek treatment when they're depressed, when they have a mood disorder, and may be treating themselves instead. So why do I spend a lot of time talking about physician suicide instead of focusing on issues that are much more common for us to cope with, issues like burnout and workplace distress? And in order to get, I think, to the positive pole of thinking about physician wellness, I think it's helpful to spend a little bit of time thinking about the particulars of this story of physician suicide. I think it demonstrates some important issues for physicians, and that is specifically that there is a problem of professional demoralization among physicians that has more to do with it has to do with more than just work. So professional demoralization can be lethal at times, and it can be extremely debilitating. And that's because physician identity is often quite central to our sense of self. We choose to become physicians at a very young age, at a very pivotal point in our adult development. We often defer other developmental milestones, marriage and family, in order to pursue a physician identity. And for that reason, it becomes quite central to the self. So it does look like work-related stressors are quite challenging for physicians in a way that they may not be for others who aren't physicians. I think the other thing this literature points out that is worth thinking about is that many of the personality styles and coping strategies that are encouraged in medical training may place us at some risk for distress. And by that I mean the hyper-conscientiousness, the hypertrophied sense of responsibility, our over-compliance, and our ability to distance ourselves from intense emotional experiences. These are things that are very useful and adaptive, and we learn to do them in training for good reason, but they can also pose problems when we become distressed. As I mentioned, the suicide data make it clear that physicians are very reluctant to seek help for depression. And so, ironically, despite our knowledge, our expertise, the fact that we sit around all day in a room full of physicians can be very isolated, especially in the face of distress. So, in other words, and in summary, work-related distress, I think, is very impactful for physicians, and it's something we need to all have a heightened degree of caution about, and not only in ourselves, but also in those around us. So let me just take 2 seconds to remind us all of a few things that you might want to remember if you ever are working with someone who you begin to worry about. I think it's important to feel confident and somewhat comfortable that if you begin to worry about a colleague, you have some sense of what to do. These are very common sense things, but I'll just run through them so that you can have them in your mind in case you ever need it. If you're working with someone who seems to be different than their baseline, different than what you're used to, they're more irritable, they seem to be angry, they're a little bit reckless, maybe careless, maybe showing up late, they're a little withdrawn, a little bit sad, I think a first good step is just to remember to think about depression. Remember to think this person may be depressed. And that's actually a very helpful first thought to have. It sets you down a nice path where you can think about ways to ask and perhaps to intervene. So there are some resources. The Suicide Prevention Lifeline is not just for those who are experiencing suicidal thoughts. It's also a line you can call to say, what can I do for a friend or a colleague of mine, confidentially. The Staff and Faculty Counseling Center here is also available, an excellent resource. One thing to do is to be assertive. We all tend to say, would you like to have lunch? And that's not the approach to take. Instead, you should say, when are we having lunch? We're having coffee, let's schedule it now. Don't give someone the need to choose. They may be actually telling you that it's hard for them to choose, so you should choose for them and be assertive about just getting a little bit of time to talk. And as we all know, asking about suicide, asking about thoughts of death doesn't plant the idea in someone's head and doesn't increase their risk. In fact, just the opposite can be very relieving. So, an easy way to start around this is just to say, are you having any thoughts about death? It's a simple question. If there is a response to that, you can ask something a little more direct about suicidal thoughts. But it's important to ask and to think about it for yourself if you're encountering someone who's depressed at all. Another thing to do is just to ask some opinions, ask for some help, enlist some other colleagues in thinking about a situation that maybe you're not sure how to interpret. So again, here's just a sort of rubric, a way to think about risk for suicide among physicians. Both genders, male and female, the risk seems to be elevated. Mid-career, later career seems to be a high-risk time. Marital status, disruption in a marriage, of course, is an important risk factor for suicide. Substance use, and also excessive overwork and evidence of risk-taking if you happen to see that. Obviously, psychiatric symptoms, tearfulness, anxiety, anger, physical symptoms like pain. Professional stresses and change to someone's job, a change to their job security, and something not included on this list that actually has been shown to lead to suicidal thinking is a perception of an error, of having made a medical error, does increase someone's risk of suicidal thinking in the next few months. So if someone feels that they may have made a mistake at work, that's a high-risk time and a nice time to ask about depression, thoughts of death, and of course access to means. Okay, so with that out of the way and accepting the importance of work-related distress among physicians, I'm going to shift a bit to talk about burnout as one label for one category of work-related distress that physicians encounter commonly. It's not the only type of work-related distress. Certainly many of you cope with grief and bereavement after the death of a patient or an adverse event, a case that doesn't go as you had hoped. Then there are second victim experiences after a medical error. And each of these are a kind of work-related distress that has their own natural history and very particular ways to intervene. And I'm just going to review for you burnout as a construct and as one way to think about the types of work-related distress that appear to be common among physicians. When I get to talking a bit about interventions for wellness, many of those interventions can be helpful for second victim experiences, for grief, and we'll talk a bit about that at that point in the talk. So burnout is just a construct. first described by Christina Maslach at Berkeley. It's been characterized, well-studied, comprised of these three domains: emotional exhaustion, depersonalization, and a lack of personal accomplishment. Emotional exhaustion is just feeling overextended, entirely drained from work, having nothing left to give. Depersonalization is a feeling of detachment from and disinterest in others. Other people feel like objects and not people. You want nothing but to control and remove yourself from the interaction taking place. A lack of personal accomplishment obviously is a sense of having no satisfaction with your job and feeling a lack of competence, success, or personal achievement at work. We talk a lot about meaning in medicine, meaning at work for physicians, and that would fit under this construct of personal accomplishment. So this is burnout, these three domains. Burnout's very important, not just because it's distressing for us, but there's a good deal of data that show that burnout is important for our patients and for our clinical systems. So burnout's been associated with turnover, a major reason that clinicians leave a practice. It also seems to impact clinical decision-making. There's very interesting work about the impact of emotion on decision-making, including ethical decision-making. For instance, the relationship between a perception of having made an error and a reluctance to withdraw care, and the way that that can cause a good deal of conflict among clinical teams. There's a pretty clear relationship between burnout and decrements in quality of care. Physicians with burnout have a higher likelihood of reporting a recent major medical event error, and patients of physicians with burnout notice it. They tend to be less compliant and less satisfied, and there have been studies that look at prescribing quality and burnout, and there's a relationship there too. Communication, coordination of care, this is kind of what we do all day long, talk to one another, and burnout certainly depletes us of our motivation and interest in communicating. So it makes sense that it would impact coordination of care and communication among a team. It also looks like it has some impacts on patient communication. Very hard to track that closely, but there have been some interesting studies that look at patient communication in burnt out physicians, and there are differences there. So the good news is, well, good, bad, is this good news? Here you are down at the bottom. This is burnout rates by specialty, a study from 2012. Very large study. Up here at the top, emergency medicine, rates above 60% of reports of some symptoms of burnout. This is interpreted as those at the sort of front line of care experience the most burnout. Can you read this? Yeah. Okay. Special case, right? So here's the mean. You know, we're about 50%, 45, 50%. I think it was 46% in this study. And this has been interpreted as those at the sort of front line, internal medicine, emergency medicine, have the most burnout. I don't know that I see that list that way, but the good news for you, you're down here closer to the bottom, around 30%, pediatric subspecialties and general pediatrics. An important thing when thinking about burnout is just a construct created to address burnout among a range of people working generally. So it's not something that's specific to nurses or to physicians. And among physicians, there are very interesting patterns about what kinds of burnout symptoms physicians tend to have. Physicians tend to get emotionally exhausted, and they tend to feel very depersonalized and detached. So 46% in this study report one symptom of burnout at least. Most often that's emotional exhaustion and depersonalization, much less commonly to feel a lack of personal accomplishment at work for physicians. So there is a sense in the data that, it makes sense. There's a kind of robustness about a sense of accomplishment or satisfaction or a feeling that work is very meaningful as a physician. There's still most physicians who would choose to become a physician again. And as I said, pediatricians tend to, the hypothesis about why pediatricians are less burned out than other physicians has nothing to do with the places they work or how things are organized, just that kids are kind of fun. So you have this continual, in a sense, repletion of a sense of joy and delight. perhaps. I don't know if you all would agree with that, but
Question?
yeah.
30% would not want to go back to medicine. Would you say that's high? Because when we were 21, we were quite ambitious at making this.
Does that seem kind of low to you?
Well, I think 30%. I mean,
30%
would
is-
be doctors again. I mean, I think it's low.
That you think it should be higher than that?
I mean, ideally.
It's an interesting question. It'd be nice to see sort of across professions how what those rates look like. It's not a question I can answer very well. When there's turnover among out of medicine, it tends to happen in training. And we see that a lot, and you see that in the most intensive specialties like surgery, that there is a lot of recidivism, people leaving surgery to move to another specialty. And that's a time when some people leave medicine too. I don't know. It's hard for me to answer that question. It'd be nice to look over time at how that's changed, other professions, and what generations those are. So a lot to say there, but that's 70% maybe should be higher. So I think it's helpful to think about the, I call these contextual factors, and I'll say a little more about that, but these are the environmental factors that have been shown to contribute to burnout. So burnout is not just having too much work. Workload is one element of burnout. Control, autonomy, the opportunity to make decisions and make choices, to say, tomorrow I'm going to leave a little bit early, and to be able to do that is very important to lessen burnout. Reward, a sense that there is an ability to receive some recognition and financial reward for your work. A sense of community in a context, that the quality of the social relationships and context is high, is very important. Fairness, transparency, a sense that when a decision is made, you understand why, that things feel equitable and consistent is very important. And of course, a feeling that you work in an organization where your values match those of the organization. A match between those values is very important for burnout. So I find this kind of interesting to think about. There's a handout that I brought that's at the back that just walks through a bit of this. These are nice things to keep in mind. They also are leverage points for someone feeling exhausted. That these are all the sorts of things that you could try to tweak slightly to feel differently. So that in a handout, it's to walk through some of this again, and if you'd like, you can pick one up as you go out. When I walk through some of the interventions that address burnout, they usually target one or two or three of these attributes. And as I said, I'm going to say a lot about community and community. Intervention. So what could we do to address workplace distress and burnout? Here I'm not really talking about suicide or serious mood disorders. Those are the sorts of experiences that no one should be trying to manage alone. That really requires a good deal of partnership with a psychiatrist, perhaps a therapist. These are instead interventions that aim to improve our own experience at work. And essentially there are two types of interventions to improve physician experience. This is my own typology. Many people might disagree with it. I think of them as fitting into one of these two categories. Before I go through this, I should say the literature on this is very thin. There have been very few controlled studies looking at interventions to address burnout, very few large studies looking at addressing burnout. But there is a lot of interest in thinking about interventions that may help. So they tend to be, first of all, focused on self-assessment. And I'll show you one of those. So self-assessment is a way to increase your own perception of control and reward and workload, sort of how much work you are responsible for. So as opposed to those 6 factors that were really studied as contextual environmental factors, external factors about a workplace, these really are interventions that change our own internal perception of the place that we work without actually changing the place we work, just how we perceive it. So you could fit biofeedback, which has been actually, in contrast to everything else, very well studied. There's a very good evidence base for the effectiveness of biofeedback in improving our ability to self-observe and understand what we're feeling. Meditation could be fit into this category too of self-assessment. Meditation is a practice of observation of the self and understanding and practicing one's own internal experience at a point in time. So the reason that I group these together, these are things that are usually done alone. So self-assessment can be done, as I'll show you, on the internet with a survey. You meditate usually by yourself, or you may be with others. It's primarily around your own experience of yourself. Reflection, in contrast, a second type of intervention to improve burnout, tends to be done with others. Doesn't have to be. Reflection can be done all by yourself too, but reflective interventions tend to be group-based. They tend to be about sharing and communicating with others, and they tend to focus on not just community, but also renewing a sense of meaning and values. And there are many examples of reflective practices. Narrative medicine is one. That's storytelling or reading or writing and doing that with a group. Many different modalities for doing narrative medicine approaches. Balint Groups, which I'll show you and talk a little bit about. Meaning and medicine groups. Short center rounds, and short center rounds are a lot like the reflective case rounds for reflective practice that we do here at Reagan, and there are Schwartz rounds that take place at Santa Monica too. So this is something done in a bigger group, case presentation and discussion in a large group, and that's a reflective practice. The key to reflection, I'll tell you about in a second. Let me instead say just a couple more things about self-assessment and feedback. So this sounds silly, very simple, but self-assessment and feedback is really impactful. And an example that someone gave to me a while back is when you are in the middle of admitting someone and you start to get a sense of this patient and this situation. And you say to yourself, okay, here we go again. And you know what this case signifies, what it's going to feel like, what might happen down the road. That ability to sort of identify the type of case you're dealing with very early is really helpful. Anticipating what's coming next is really helpful. And assessment and feedback gives you that skill. So just hearing a little bit about, oh yeah, this case that just happened, it was really difficult for this reason, then the next time it comes along, you're able to catch it much more quickly and you're much more prepared. So self-assessment and feedback is pretty helpful. So this is a great brand new study about an individualized online feedback approach that was used with a large sample of physicians. As I'll show you, in the intervention, they not only did self-assessment online, ratings of well-being, of depression, of satisfaction, of burnout, of meaning at work. And then in presenting the feedback to the participants, they really aimed to leverage physicians' competitiveness and use that to improve their motivation for change. So at the end of using this online interactive assessment and feedback protocol, about half of the participants indicated they were considering making at least one change to reduce burnout. That's pretty significant, actually, that someone would say, I'm considering making a change. So this is the feedback that they give to the physician after they complete the self-assessment exercises. First, they say at the very top, your score indicates your well-being is above average. Second, they say your score indicates an average level of well-being compared to other physicians. Now, who wants to be average compared to other physicians? That's their thought, is that phrasing things in this way, and then that's what they do down here too. They show you, here's your score and on career satisfaction, and here's the average. here's your score, and here's the average. Here's your score, and here's the average among physicians. I think in this they use both these sort of all data. They use the data from the study, and then they use other studies to show what an average rate might be for physicians. So this individual did pretty well, but you can imagine if you're down here, you might feel like you need to catch up a bit. So that's how they structure this. I thought that was very smart. The other thing they found in this study, and I don't really have time to show it to you, but the physicians were generally very bad at assessing their own well-being and also their relative well-being compared to other physicians. So they were pretty inaccurate. You know, they would guess that their sense of meaning was about average or maybe even above average, and in fact they were way down here. So that, you know, that suggests that actually we may not be very good at understanding how we're feeling and how we're experiencing things for ourselves and also in relation to others. So that's a self-assessment example. So reflection, and I'll just walk through a couple of reflective approaches. And by reflection, what I mean is a chance to slow down, to connect the past and the present, to question assumptions, to look at multiple perspectives. There are many ways to do this. One example is debriefing. Debriefing is an approach used very commonly, and again, this is not so much relevant to burnout, but this is something used frequently following adverse medical events. There's an excellent peer support service at Brigham and Women's Hospital that provides confidential, peer-based, immediately available peer support for physicians and other providers who have experienced an adverse medical event. So it's peer support. It doesn't have to be a physician, but it needs to be someone who is credible to you. It's confidential. There's a firewall between this process and anything else going on with risk management. And it's a way to link people who may need further help to more intensive services too. So that's an example of a debriefing intervention. This is also done routinely, commonly among teams that are working together, and there's an example from 2004 that I showed you as well. So, and as I said, Schwartz rounds, meaning in medicine, literature in medicine, which is an approach used in the VA across the country, are reflective approaches that again just allow people to slow down, talk together, question some of their assumptions, and look at multiple perspectives. So one of the oldest reflective approaches, I'll just tell you a little about this because it's the approach I'm most familiar with, and because it's a very old approach that I think includes a lot of the elements that are common to other reflective approaches. It's called a Balint Group, and I never, whenever I have an opportunity to show this lovely picture of Michael and Enid Balint, I always do it because it just makes me happy to see them looking so sophisticated. This is Michael and Enid Balint, B-A-L-I-N-T. That's what the Balint Group is named for. They were psychoanalysts in the UK in the 1950s. And they developed this group-based approach to help physicians think about the psychological aspects of medical practice. To put it succinctly, think about the psychological aspects of medical practice. Michael Balint coined the phrase patient-centeredness, and he said famously, at the center of medicine, there is always a human relationship between a patient and a doctor. Patient and a doctor, I think that's still true today, and the Balint Groups really work on that premise. So Balint Group is a group of 8 or 10 physicians. Doesn't have to be physicians, it can be any kind of clinician. It can be, Balint Groups are done with clergy, with a whole range of different kinds of professionals. 8 or 10 people come together in a group, and there are classically 2 leaders of the group. The group lasts for 45 minutes. First thing that the leader does is call for a case. Who's got a case? The case appears. Someone in the group says, I have a case. So this case emerges spontaneously. It's not planned. It comes up in the moment, sometimes after a long silence, when it feels like no one's going to have a case. Someone says, I have a case. This person becomes the presenter. And a case is a troubling patient. A patient that's troubling. A patient that wakes you up at night. A patient you carry around with you. A patient that's confusing. A patient that's difficult. Ideally, it's an ongoing case, someone you may see again. That's a case. So the presenter describes the case. Angela's a 79-year-old blind woman in my practice. I saw her last week. She had complaints about this and that. The presenter describes in about 5 minutes this case and what's going on. The others in the group can ask some questions if they need to, but once that's done, 5 minutes or so, the presenter gets to just listen. The presenter hands the case to the group, and the group works the case. So the group probably don't know this patient, I've never seen this patient. They begin to speculate and imagine who this patient might be. I'm thinking she might really be trying to get from you something about what's going on with her son, not what's going on with her. So the people in the group begin to try to think through what might be going on with this patient. They also start to think about what might be going on for the doctor with the patient. So if I were in this case, or when I was last in this kind of a situation, I felt this way. Begin to think about the doctor. And then they also begin to think about what might be going on in the relationship between the two of them. So that's their agenda as a group, to think about the patient, think about the doctor, and think about the relationship. And that's what they do for the rest of the time, for 45 minutes. The presenter just listens. They might say something at the very end, join the group, but they don't need to. The idea is the group practices putting themselves in the shoes of the doctor, the patient, and imagining themselves in this relationship. And they take care of that case for a brief period of time for the presenter to give the presenter some relief. And then the group ends, and that's it. It's not a process group. You're not talking about the things that are bothering you that happened yesterday. It's not a place where people bring up what's going on with them in their own personal lives. Occasionally that happens, but it's really focused on the patient and working this case. So there are a lot of reflective interventions that include some of these key elements of a Balint group. Group-based support, a safe space for reflection, time, protected time, and some focus on profession and work-related issues in a way that's pretty safe. You know, it's just talking about a patient, so people who may not really be very interested in thinking about their own internal experience can often think about what it's like to work with a particular patient. So this is another recent study of an intervention, a reflective small group intervention, and this is my just last peek at a type of intervention for reflective practice. What West and colleagues did in this great study, which really warrants a read, there's also an excellent commentary about this article that accompanies it, and I wrote about it here on my webpage, so you can look to see what I thought about it too. This intervention was every other week, 8 or 9 physicians meet in a small group for an hour. They did that for 19 sessions, and they talked about topics relevant to medicine. They talked about medical errors, they talked about patient care, they talked about working with families, they talked about burnout, and the control group had an hour of protected time every other week to do whatever they wanted with it. The intervention, the group intervention, increased many aspects of burnout, sense of meaning and empowerment, and there were gains especially in depersonalization. And I think depersonalization is very important. So depersonalization, again, is this sense that other people are objects and not people. And you can imagine how hard it would be to feel that the last thing you want to do is deal with another person and to be working in a hospital all day long. And you can imagine how hard it is to actually take care of a sick patient when you've lost track of the fact that it's another person in front of you. So I think depersonalization is a pretty important construct to think about, and it's nice to see that this very simple group-based intervention improved feelings of depersonalization, and those gains were maintained at 12-month follow-up, actually. The other striking thing about this study is that the control group improved as well. They actually had a comparison group of about 350 physicians who did neither of these interventions, and their burnout scores got much worse over the time of follow-up. But those who were either involved in the intervention and those in the control group improved. So something very bad was going on generally for the physicians who were simply being tracked in this study. But those who had even just 1 hour every other week to do what they wanted with got better, felt better at the end of the study. So again, my point is it doesn't take a lot of time. It doesn't take a lot of money. It doesn't take anything too radical to make a small intervention that I think can help physicians experience work a little more joyfully and meaningfully. So just in concluding, to point out a few of the things, there are many things going on locally that can be useful to you. And I always refer people to the Stanford Well MD website because it's gorgeous. There are a lot of resources there, including this page that just is a bunch of self-tests on a whole range of different kinds of things, burnout, anxiety, depression, wellness, physical health, and it's a nice place to just spend a little time looking around. It's also makes me sort of leveraging that competitive aspect too, that we should have something like this. It's actually a great resource. Short Center rounds do take place at Santa Monica Hospital. The next one is on April 22nd. As you all know, there are also case rounds for reflective practice that happen here at Reagan. I think the date for the next one is not yet set. I understand there's also ad hoc debriefing for those who need it or would like it in your department, which is terrific. There are meeting and medicine groups that go on regularly on campus. And I've been asked to tell you, too, that there is an interest in learning from you about what you think would be helpful. So a survey that will ask house staff and faculty to elicit some preferences for reflective practices, self-care strategies that you would like to see. And the aim is to develop workshops or a curriculum that can really suit your needs. And if you would like to get involved in this, I think we would really love that. Please do. The more, again, community, the more people who want to take a little bit of initiative and do some of this, the higher value it will be. So collaboration, engagement is really very welcome. If you're interested in research on this area, I'd love to talk with you. I will try to help you. I may not have precisely the expertise, but I would love to hear about your interests, and it may be that there would be things that we could do together, even small things. So if you have an interest in some of these issues, interventions to address burnout, and you know what? I don't know how to go backward. There we go. At the very end, I get it. So let me know if you have an interest in any of these issues. And this is my program web page and my email address. And I want to thank you very much for your time today. I should thank Ariel Lasky, who is a medical student who's doing some research with me and was offered some terrific research assistance on this project. Thank you to Dr. Federman for inviting me. And thanks to those of you, some of you may be here, who have done an interview with me for my book project. And thanks to those of you who are here today for your future involvement. It's going to be great to see what happens from here.